excited to present a distinguished speaker in the realm of technology and philanthropy. Please join me in welcoming Indira Negi, Senior Advisor at the Bill and Melinda Gates Foundation.
Hi. Good spot. Hi, everyone. Thank you all for choosing this talk, because I know this is one of your 4 options. And I was saying that I myself might have gone to another talk. So I'm going to talk about AI in healthcare. That doesn't look like my first slide. All right. And you're going to learn today about new products that are made possible through AI that a few years ago we couldn't have made. We'll of course talk about challenges because it keeps life interesting, and then I'll touch upon funding, both equity and grant funding. I work at the Bill and Melinda Gates Foundation, which is one of the reasons I must talk about grant funding. There was a brief intro before, but I don't know if it was well heard. I used to be at AliveCore, which is an ECG device company. I brought it along because I'm going to show you how it works and how it has been made possible because of AI. And I used to be at Intel before that. I'm an engineer by background, mostly worked on health sensors, medical devices. And I'm found on LinkedIn and Twitter, or X, whatever your preferred name for the platform is. And an interesting tidbit about me, I grew up in India, in the Himalayan foothills, which will also feature as a health application. And I live here in San Jose now, in the Bay Area. OK, this is not an error slide. We've had a good talk. You've absorbed some information already. What I like to do, and one of my favorite parts in my job, is actually going to the field, going where the work is getting done, spending time with the patients, the healthcare workers who are using the technology. And so what I would love to do is have everyone just close their eyes for 30 seconds. Let's close our eyes. And take a deep breath. All right. So we're going to a village in Kenya, Africa. It's a dry, dusty landscape, pretty arid, sandy and rocky. It's a very hot day. There is a young woman. Her name is Bakita. She is walking on a dusty path towards a small building. This is the village dispensary in her village. She is pregnant, so very likely she's going for her pre-pregnancy check. All right, you can open your eyes now. I couldn't find a picture of the dispensary without all of us posing in front of it, but this is what a village dispensary looks like in Kenya. This village is called Shangia. It has 4 rooms, and one of the rooms is actually a delivery room. So babies are born here, about 8 babies every month. Let me take you into the delivery room. Don't worry, there's no delivery happening. So what we're seeing here, this is an auxiliary nurse midwife. There is only nurse midwives at this dispensary. There are no doctors. So if a woman showed up here and she needed a C-section or a blood transfusion in case something went wrong, there's nothing they can do about it, right? That would result in a bad outcome. The mother might bleed, the baby might die, right? So what we've done here is this is a pilot program. This nurse midwife is using a point-of-care ultrasound. So let me talk about why an ultrasound is very necessary. So the cases which are going to be high-risk births, you can often find out in an ultrasound. If the baby's position is breech instead of normal, that woman very likely will need a C-section, and you can't do a C-section here. If the mother is anemic, she is very likely going to need a blood transfusion. You can't do a blood transfusion here. So what you want to do is have women come in for a pre-pregnancy check, find that they are high-risk women, and if they are, make sure that they are signed up for their final delivery at a higher care facility, which means that they have to go earlier, they have to be admitted in the hospital or a clinic before. So the pre-pregnancy checks or the antenatal care checks, they are very, very important. So important that the Kenyan government has spent a lot of budget and dollars counseling and educating women on coming for pre-pregnancy checks. That is also the WHO guideline. And it took about 15 years, 2008 to 2014, and the rate of women coming for their 4 pre-pregnancy checks went up by about 20%. 2 years of this pilot program, the rate of pre-pregnancy checks went up by another 20%. So when I was there, I asked this lady, Bakita, why did you come in the hot sun? You had to take a day off of work. It's uncomfortable, and women don't usually come. Oh, there's also some cultural context to it. In a lot of countries in Africa, it's considered a weakness if they have to go to the hospital to deliver a baby. Like a strong woman should be able to just have the baby and go about her life. So you're fighting against a lot of culturally deep-seated beliefs. And Bakita said that I came and I did all this work, took the time off of my compensated work, because I get to see my baby's heart. I get to see it opening and closing the valves, right? And for them, this is such a huge thing, because a facility like this could never have had an ultrasound. In fact, in Kenya, in a whole state or a county, there is one ultrasound machine, and there's one person who can read an ultrasound. So most women never get it. I was going to focus this talk initially on how do you increase patient engagement. And so if you're building products in the healthcare space, and you want your patients to do work and be engaged with your product, give them a reward for that work. That's how you get patient engagement. All right, so what I'll do next is I'll play a video. The context of that video, this is Philips's video. They've partnered with the Gates Foundation to bring a product like this to market. The real problem, well, there are 2 problems with not having ultrasound everywhere. One is ultrasound machines are really expensive, but that problem is getting solved. There are point-of-care ultrasound machines being built by manufacturers that are in the $5,000 range. There are overseas machines that are in the $2,000 range. So the cost is coming down. The other huge problem is expertise. It's very hard to actually do an ultrasound and interpret what you're seeing. And you cannot produce so many experts in so many different countries very quickly. So we are trying to offload that task to AI. And I'll let you watch the video, and then maybe, because you're all developers, explain a little bit, not too much, a little bit about how it works. Did you roll the video?
Each day, nearly 800 women around the world die from preventable causes related to pregnancy and childbirth, with 95% of maternal deaths happening in low and lower middle income countries. Affordable access to high-quality maternal care during and following pregnancy and childbirth can help reduce these high mortality rates. In addition, in many areas of the world, there is a shortage of trained sonographers, coupled with equipment shortages and long distances to travel to reach dedicated healthcare facilities. To tackle this, over the past 2 years, Philips has been using disruptive technology to develop a prototype of AI-driven algorithms. The solution is built into the handheld Lumify ultrasound platform, and through the use of AI, interpretation of the images is not required by the operator. Instead, 6 critical parameters are identified to provide expectant mothers a health check of their unborn baby. Following a short training program, nurses and midwives will be able to perform this exam. If further investigation is required, patients can be referred to a credentialed sonographer for image review. In a rural-based region of Kenya, a pilot of this ultrasound-based prototype is ongoing. Thanks to a cumulative $60 million grant from the Bill and Melinda Gates Foundation, we can continue the development of this impactful solution. After productization, this solution will be able to help reduce maternal mortality and morbidity, with the goal of transforming the delivery of maternal care.
All right. Before I talk about what's on this slide, I want to say Philips is not the only company doing this. We've partnered with Philips, which is, I like to call it the Apple model. It's fully vertical. They make the hardware, they make the software, they distribute, go to market. But we're also invested in a company called Caption Health, which is the horizontal model, or what, like an Android, or how I pitched it inside the foundation, like Windows. Because they would make the software, they get the software FDA cleared, and then any hardware manufacturer should be able to license it, which means that AI, to be able to identify the high-risk parameters in the hands of a novice user, that technology should be available on every ultrasound device that exists, whether it's $1,500 or it's $10,000. So our vision is that every woman on earth gets a pre-pregnancy, high-risk scan, and it's not limited by expertise. Okay, so what's happening here? Now, because this is a technical audience, I don't always pull out the slide, but for this audience especially, I have the slide. So these are two seminal papers. This work was actually pretty seminal because nobody thought that this kind of thing, you just do blind sweeps and don't even look for the right images, and you'll still be able to find the high-risk parameters was possible. So for people interested, I would urge you to go check out these two papers. The second paper is actually by Google. So a lot of this work initially started with Google research team. The first one is from University of North Carolina. And we have the study is nicely named Fetal Age Machine Learning Initiative, or FAMLY. So much so that we all call it FAMLY, and we'd forgotten what the acronym stands for, and I had to dig it up for this talk. But coming to the crux of it, this is what a traditional ultrasound looks like. So an expert has to be really good at capturing these images, which means the right angle with the probe, knowing how much pressure to apply, so the ultrasound waves will penetrate just to the right depth. Knowing that if they found the head, where is the rump going to be, like where is the, how the baby sits inside. And this takes years of practice. Like I'm not a dumb person, but I'm never able to capture a good image with an ultrasound, no matter how much instruction has been given to me. So the standard method is you capture really good high quality images, and then you measure things in those images. So you capture the head, you pull out a ruler, you measure the circumference or the diameter of that head. And then you estimate what the gestational age of this fetus might be. And then you do various interventions based on that. Is the baby small? Does that mean the baby's growth is restricted? What are the interventions you might have to do? So it's a really hard thing. People go to school for years to learn how to do this. What we're doing now is just blind sweeps. A novice is just going up and down, left and right, and we're not capturing any high quality images or frames, not even trying to capture standard frames. And then when you feed both this dirty video data as well as these clean images into a model that FAMLY has developed, out you get gestational age, and out you get the position of the baby. Out you get other risk factors that are complex technical clinical technical terms. So I think it's quite magical, but briefly, this is roughly what the procedure looks like. You get the patient's data, consent, you have an expert collect really high quality data from different devices, and then you have novices collect that data, and that feeds into the model. And this is the very last slide, but this is the conclusion slide. So if you look at, so on the y-axis, you have the percentage of estimate that falls within, say, 7 days or 14 days, a percentage of estimate of the right gestational age of the fetus. Have I lost some people? We are trying to find the gestational age. We're trying to find it through blind sweeps. And look how well the model is doing. So model's in blue. The expert doing measurements is in orange. the model is doing as good as, if not better, than the expert. And the model is in the hands of a novice user, like me or you. And the thing is, if you were saying, hey, but this is no better than the expert user, you have to remember that these women never had access to the expert user, right? These women are going from this red line, which is the last menstrual period, which is what is used to estimate the age of the fetus, which can be so far off. It can be 30 days off, and then you're doing all sorts of incorrect medical interventions. These women are going from the red line to the blue line. So it's a huge improvement. Okay, this is the conclusion slide on this story. I hope this was inspiring. Now we're going to shift to the heart. Let's talk about the human heart, because I think it's a topic that's close to many of us. Many of our family members suffer from cardiovascular disease. So atrial fibrillation, I think nowadays is pretty well understood, but I'll do a quick primer for people who may not know what this is and really how ECG is measured. So if you see the heart on the left, that is a normal heart. The top two chambers are supposed to squish together, drive all the blood to the bottom two chambers, then they're supposed to squish, the valves close, drives the blood to the rest of your body or to the lungs to get oxygen, right? What happens when you're having atrial fibrillation is there is some electrical impulse that goes rogue. And instead of both of your top chambers squishing together and then the bottom chambers squishing, they're squishing at the wrong time, which means some blood is leaking back in, some blood is not reaching that's just a bunch of leakage. Just you don't have good closure of valves. What that means is you're not getting enough blood in your organs and in your muscles. So people typically will feel weak and they'll feel dizzy. And sometimes they'll feel like their heart's racing really fast. That's called palpitations. Now, because this is all electrical impulses, and when the muscles beat, they create electrical potential, we can measure them in an ECG. And this is what a normal ECG will look like. And that's a not normal ECG because your heart's squishing the wrong chambers at with the wrong beats. I'm trying to explain it in the least medical manner. So earlier, like if you had atrial fibrillation, what you would get was a doctor that would send you home with something like this. This is a Holter device. And I say earlier, but in most of the world, even today, that's what you'll get sent home with. You'll just have these leads on you. You'll wear this for 24 hours to 7 days. And they'll try to catch episodes of atrial fibrillation. They'll try to catch episodes of irregular beats. And and in the US or developed nations, you'll get a patch that you can wear for 7 days or even 14 days. And if the doctor cannot catch an episode of irregular beat, then you can even get an implantable device. So it's a tiny little thing, implants right under your skin. You can keep wearing it for 6 months. It records every irregular beat. You can actually wear it for 3 years, but they're only paid to read it for 6 months, so they just take it out after 6 months. Now, reimbursement's a whole other topic, another talk. But about 12 years ago, so this is the company that I was part of. I'm a huge fan of the founder, Dr. Dave Albert. But they started this company called AliveCore. He's a cardiologist himself, and he was like, this is ridiculous. Why is it so hard to just capture events like this? So with something like this, you can just have it in your pocket, in your purse, and if you feel dizzy or you feel palpitations, you can just measure an ECG right on the device. With this one, you can measure a 6-lead ECG, like there's an electrode at the bottom, and you can place it on your feet and measure 6 leads. All this is possible because of AI. Nowadays, you have a single lead ECG on your Apple Watch. You have it on a Google Fitbit as well. But AliveCore gives you 6 different interpretations. Each of them is a new AI algorithm. Each of them does take a separate FDA clearance. But this would not have been possible without the AI. So this is just like an example of what's possible now. Moving on, because we can't talk about new products or AI without talking about generative AI now, since the world has been taken over by large models. These two were examples of traditional AI. which we understand well. Imaging AI has become actually quite accepted. The FDA knows how to regulate these devices, how to provide clearances. With generative AI, I think there's some challenges we'll talk about, but it's so new, and there's so much potential. This is a DALL-E 3 image. This is what it thinks generative versus traditional AI looks like in healthcare. All right, just waiting for the slide. OK, so what I've done is actually picked, OK, I'm going to play a video next, but I'll give you some context. So the Bill and Melinda Gates Foundation recently funded 50 different grants. They were all in low and middle income countries that were using large language models to solve a problem in health or education or agriculture. And 50 is a lot, so I have curated 2 of them that to showcase and share with you guys. And I'll play a quick clip by my boss, Bill Gates. This is from last month from the global conference that we hold every year. And then I'll talk about the two projects in generative AI healthcare. So if you could roll the video.
So, Bill, you've said that AI changes everything. But that's expected of you to say. You're a tech guy. You're the tech guy. Do you genuinely think this is a game changer?
Well, it's very early days in AI, and that's why it's so impressive that already we see these 50 innovators here in Africa, literally a year after the first LLM breakthrough, ChatGPT-4 got out there. And so part of the goal is to have these applications that reduce inequity not be 10 or 20 years later, have them be right on the cutting edge. And that's why it was so fascinating to see the breadth of problems that were tackled by these innovators. A lot of health, agriculture, financial services, education. And as we go into the next phase, where we're just committing today another 30 million of grants from the foundation, and this focused on the African innovators, we'll be helping them group together around some of these areas and take their application to the next stage. And a lot of these things are already in pilot mode. We need to prove out the value, see what the challenges are. So, I'm thrilled, and I do see, when you say there's a shortage of teachers, a shortage of healthcare workers, that the R&D for new medicines doesn't go fast enough. The reason I think we can improve every one of those things is that we'll take local innovators and use AI as a tool of productivity.
OK, so what he said. I think I'm going to move a little bit faster. I was going to do another close your eyes for 30 seconds, but I think that's just to go straight. We're going to Nepal now. If you watch the Doctor Strange movie, that's how Nepal is. Temples and mountains. It's also close to where I am from. So the Nepal Applied Mathematics and Informatics Institute, they worked on this chatbot to help young people, new brides, et cetera, with information about sexual, reproductive, and maternal health. The big problem that was happening in Nepal is a lot of unsafe pregnancies and sexually transmitted diseases. They were growing. But because these topics are so taboo and there's a social stigma around it, especially in a lot of Asian countries, young people, students, young brides didn't want to talk to their family members, so they didn't want to talk to healthcare workers. And so there was just this lack of information. And so they've built this chatbot that's in Nepali, so it's using the local language, and it's providing information. These are just like images of school kids, young brides, some sitting with their mother-in-laws, and generally young teenagers using it. And it's actually been quite successful. And this is a theme. So this is one example of something like this, but we have a similar application in India. We have a similar application in Vietnam where they're providing information about sexually transmitted diseases and reproduction, but because they're taboo, people just haven't been able to seek out that information. And it's so interesting because people are so comfortable talking with a chatbot. They will share stuff with the chatbot that they will not share with anyone in their families or any healthcare workers at all. And so we think this is like a huge area. Like anything that's taboo, make a chatbot. Right? Because we're seeing like really high engagement and good outcomes, right? Because like once they know that this is actually a problem, then they can go seek out a healthcare professional. All right, the other type of example. So this is out of India. This is essentially like a copilot, like a GitHub copilot for the frontline healthcare workers. So these are nurse midwives and community health workers. And so I know I say nurse midwives, and that sounds like somebody's a nurse, but that's not true. Most of these people have like 10th grade education or 12th grade education, and then they've done some course in addition to be able to do basic blood pressure testing or draw a little bit of blood to do like a hemoglobin test. So they're not very highly educated, and so that means that they're taking direction from the doctors that are above them in the system all the time, and they're teaching the women in the villages about it. And so these guys have built a copilot to manage high-risk pregnancies. And this is in English and Telugu. Sorry, I was like not going to say, one woman dies in childbirth every 20 minutes in India, so this is very, very needed. And so this works in both languages. And we've seen a similar copilot for nurses in Tanzania and a similar one in Brazil. And so another type of application that's actually a common theme that seems to be working really well. I think I'll go into one of the issues when people are using two languages. So large language models are very good at one language, right? They're very good when you're talking to them in English, and they respond in English. And they're very good if you're talking to them in, like, say, Hindi, and they respond in Hindi. But that's not how people in most countries operate, right? Everybody is constantly switching between Hindi and English, or Swahili, like Swahili and English, or Telugu and English all the time. And LLMs get very, very confused. So this is an issue that has to be solved. We're looking for solutions. If you know any, please, please tell me after this, because that is one of the big sources of error. And I thought this was a funny picture, because this woman is reading printouts on paper of some other nurse having chatted with the chatbot. It's funny, but I also think that it points to the fact that this way of consuming information was so much more efficient for them compared to like having read the books and the brochures. Because the nurses were like, oh, I use this chatbot, I got this answer right away. It was very, very useful in this situation that occurs in our life every day. Why don't you all read my chats, right? So I think it speaks highly of this method of communicating information. What is happening? All right, let's talk about some challenges. Because we're talking about LLMs, I'll just first go into that. So this previous example that you saw, what we are seeing is that these nurses and midwives are actually addressing this chatbot as sir, because they're so used to their communication device information coming from their superiors that they are assigning the bot this level of authority. And the danger with that is we all know these LLMs hallucinate when they don't know the answers to something. But these guys are not questioning it. So they are taking the word of this bot as gospel, even when it goes against stuff that they've been educated on. So this group actually did test the reaction of the nurses by giving them more and more incorrect responses. And they had to keep increasing the magnitude of wrongness. Before, the nurses were like, no, this is definitely wrong. We can't go do this. So I think there's a huge danger here. And some research needs to go into what kind of persona should this chatbot have. There's this one group that's working on gender-based violence, and they did some research into it, and they assigned their bot the persona of a friendly aunt. Because if you are a victim of, say, domestic violence or abuse, apparently the most comfortable person to talk to is a friendly ant. So I think we need to, instead of just putting chatbots everywhere, I think we need to pause a little bit and take this into account, that people are going to treat this as the truth. All right. The second one, regulation. I don't think this is new. There's always a regulation challenge with healthcare devices, and it is a challenge, but it's also necessary. You obviously do not want to be using healthcare products that are unregulated. When you are going to the FDA with an AI algorithm, it does add time and cost. So typically, if you say, hey, I'm going to read ECGs, and I'm just going to do peak finding, and then I'm going to say this is the rhythm and this is normal, the FDA will be like, sure, I understand it, test it on 100 patients. If you go to them with like, here's a black box, it always seems to have the right answer, but I don't know how it works. The FDA says, okay, test it on 800 patients, right? And that's a lot longer trial. It's a lot costlier, but it is also a moat, right? It prevents your competition from catching up very quickly. All right, last one, generative AI regulation. I think it's unclear. It's uncertain where this is going to go, because the things we're using LLMs for. Oh, are we out of time? Oh, shit. OK, sorry. OK, very quickly, I'll flash some graphs. Give me one minute. All right. We're going to move to funding, something positive. So I pulled these last week, so this is very current. If you look for equity, venture investment in health AI, it's been going up. 2023 actually has a significant amount of deals in health AI. This is a list of companies that received a lot of the funding in this period. I'm going really fast, so if you want to take pictures, do it quickly. And then deals by geography. So this is where much of the investment has gone. Luckily, we are in the US, where almost half of the investment's going, and then in California as well, as is expected. And then these are the top investors based on number of deals. And I hope this is large enough for you guys to get a picture of in this period. OK, so I have to touch upon grants, because if you're working in an important field like healthcare, you should definitely be exploring grants as your first venue. There are lots of foundations. There's a lot of government grants. This is an example of an NIH grant that we recently partnered with them on. But if you go on NIH, go on their challenges.gov page, you will see lots and lots of sort of calls and challenges in areas that they want to invest in. There's a ton of foundations. Gates Foundation is one of them. We have a grant opportunities page as well. These grants are small, but these are a way to get into the system. It is a way to find out what the foundation cares about, which is very, very important. So if you go down the grants path and don't want to waste your time, you should know where the foundation invests and really go deep into it, because this is a busy slide. But if you say, I'm working on cardiovascular health, there's no cardiovascular health on this page, which means that there is no budget for it. So don't spend your cycles trying to get funded from a foundation that doesn't invest in it. All right, that's it. That's the last slide. Thank you.